Well, good morning. I'm Dr. Rebecca Johnson. I'm the Chief Executive Officer of the American Board of Pathology, and your leadership has asked me to speak to you, the ASCP Residents Council, about our examinations, certification in pathology. I have nothing to disclose. I am a full-time employee of the American Board of Pathology. A good resource for you is our website, so it's pretty straightforward, abpath.org. And a reminder, our mission statement is to serve the public and advance the profession of pathology by setting certification standards and promoting the lifelong competency of pathologists. And lifelong, I just want to emphasize that once you become certified, you will have a lifelong relationship with the American Board of Pathology. So what is certification all about? Well, if you are board certified, you have demonstrated to the public that you have the requisite knowledge, judgment, and skills in pathology or a subspecialty of pathology to practice safely, competently, and independently. In using ACGME language, you're able to engage in autonomous practice. Now, that doesn't mean that you have to go it alone, but it means that you have the judgment and skills to practice independently, but of course, professionally, when you need help, you want to always ask for help. So up until this year, our exams were given in the spring and fall in our test center in Tampa, Florida, and in the spring also in the test center of the American Board of Radiology in Tucson, Arizona. The examination is computer-based. The questions are all multiple choice, single best answer questions. You have a countdown clock, so they are timed exams, but there's generally, for most all candidates, there's sufficient time to complete each section of the exam. We report only pass, fail, and if you pass, you get just that. Congratulations, you are a diplomate of the American Board of Pathology. We do not release scores for individuals who pass because we recognize that they may be inappropriately used in the profession. However, if a candidate does fail, we do provide them with a scaled score so that they get an understanding of how close or far away from the pass point they were. We do public reporting of certification status and just that. So if we're contacted, we would only say someone is a diplomate of the American Board of Pathology, they're certified in anatomic and clinical pathology, and that's all. We don't report whether somebody passed or failed the exam. We do supply program performance reports to your program director on an annual basis so that they know what the pass rates for their trainees has been. And we also report this data by program to the ACGME. And that ACGME report does not have the names of individuals. However, the program performance report that goes to the program director does have the name of the pathologist. Here's a nice scene of our exam center in Tampa. We've been giving exams there for about 25 years. Each candidate has their own cubicle with their own computer and microscope. There's good lighting, there's good ventilation, and it is quiet. We allow earplugs if you need even more quiet. And this is just another view of the exam center. We seat approximately 65 candidates each day, and so the exams run until all candidates who have applied have had the opportunity to take their exam. You can bring your own microscope if you'd like. These are student microscopes. They have a 4X, 10X, 20X, and 40X. Well, this year is a little different about exams. So this spring, we realized that with COVID-19, no one was going to be wanting to travel to Tampa. So it's been a journey. Initially, we said that we would not be giving exams until the fall, and we made contingency plans on how we would clean the exam center every night, how we would have social distancing, we would only seat half the candidates. Well, that went away also as this has gone on and on. So starting in June, we realized that it was very unlikely that we would be able to have fall exams in Florida. So we began to pursue remote testing. Not something that we're too happy to do because of concerns about the security of the examination. We have been giving remote exams for quite a few years for our continuing certification exam. However, that is not the same high stakes as an initial certifying exam. And therefore, even though it is a secure exam, it's not the same high level of security that we want for an initial certification exam. However, we really wanted to be sensitive to our candidates. We know that they've worked hard, they've studied hard, that they want to take this exam, they want to get it over. So as I said, we pursued remote testing. So we're using the same company that we've used for our continuing certification remote exams called Assessment Systems, and they subcontract with a company that does the proctoring of the exam. So there will be live teleproctoring. So a candidate will log in and they will have a chat with a live proctor who will monitor them throughout the entire exam. You can take the exam from your home or office. It has to be a secure testing environment, so your tabletop has to be completely cleared of everything but your computer and a cell phone. We have technical requirements which are posted on our website and have also been emailed to our candidates. There are specifications for the computer. I think the most important thing is to have a very good internet connection. A wireless connection probably is not going to serve through the entire length of the exam, and there's a high risk of getting disconnected. So a good internet connection is perhaps the most important thing. You will be monitored by the camera on your computer, a webcam, but you will also be asked to have a smartphone and use the video monitoring on that smartphone as well, so that the proctor will be able to see you face on, but also will be able to monitor your testing environment. And again, this is, for your protection and security and the security of the certification process. Candidates will get a login to do a practice tutorial with a live proctor so that they get a sense of what the actual experience will be on the day of the exam. They will be assigned an exam date and time, and we have to do that because, again, we have to schedule with the live proctors. So it can't be done anytime, any date. Can be done anywhere, however. Again, because this is remote, all of the former glass slides that were on exams have been scanned for virtual microscopy, so that will be a little different than what you're used to when you come to Tampa. So again, all virtual microscopy questions. And because of the length of the exams, several of them will be over 2 days. So the anatomic pathology exam will take place over 2 days with a little over 5 hours each day. Also cytology and derm path. And that's primarily because they have fairly large microscopic sections that require a lot of virtual microscopy. There are a lot of scheduled breaks on this remote exam. So generally, it's been divided into small sections lasting approximately an hour, and then a 10-minute break, another hour of exams, 10-minute break, another hour of exams, a half-hour break for lunch, and so on throughout the day. Candidates do not have to take the breaks, but it does give them an opportunity to get up, leave the testing environment, use the bathroom, get a snack, whatever. We will allow drinks on proximate to the testing area, however, no food. And again, the practice tutorial will go through all of those requirements and what people need to do in anticipation of the exam. We plan to, continue to push out information and post frequently asked questions about this. It's something different and it's something new for all of us. So, please bear with us. We're doing the absolute best we can in these most unusual circumstances. And we certainly understand the stress that all of this is causing you all, as well as our staff. I also want to say that to provide these remote exams is a significant expense to the American Board of Pathology. However, we are not increasing the fees to our candidates for them to take these remote exams. And finally, one other thing, again, the security of the examination and the integrity of the certification process really relies on the professionalism of you all to in no way cheat on the exam. If there is evidence that there's been significant security breaches or cheating, it's likely that we will have to invalidate everyone's examination. So you're not only cheating yourself, but you would be cheating all other candidates taking the exam. I know that sounds harsh, but again, for certification to matter and have its value, there must be integrity. So on our website, there are exam blueprints, which give you a rough idea of the distribution of questions on the exams. We have different sections of the exam. There are a written section, which are primarily recall questions, which we're getting away from more and more because it's so easy to look things up. And then the exams have two practical sections, and they are weighted towards the practical questions. However, all sections of the exam are scored together as a single examination. And of course, if you were coming to Tampa, the microscopic section of the exam would include both glass slides and virtual microscopy for anatomic pathology. For clinical pathology, there are no glass slides and there is no virtual microscopy. So again, these are the sections of the AP and CP exams. So the AP has a practical with images. So that section has a lot of cytology questions so that everyone's seeing the same image, glass slides, and now with remote, all virtual microscopy. The clinical pathology exam has images, it has it has images. There are also a lot of graphs, charts, the blood bank panels, and interpretive type questions on the practical portion. So where do these exam questions come from? So the American Board of Pathology actually has 15 test development and advisory committees. 2 of those are for continuing certification, but there are 13 for our primary and subspecialty exams. So we call them our TDACs, Test Development and Advisory Committees. And these are made up of subject matter experts in the various fields. And you can see who the members of the committees are. They're on our website, and they are names that I'm sure many of you will recognize. There are some of our exams that are jointly sponsored. So, for example, clinical informatics is with the American Board of Preventive Medicine, dermatopathology with the American Board of Dermatology, and molecular genetic pathology with the American Board of Medical Genetics and Genomics. So exam development begins with these test committee members meeting annually in our office in Tampa. The members are responsible for writing, reviewing, and editing the questions. They go through each question and make edits. They accept, sometimes reject questions, and review the images and the glass slides. Each TDAC has a trustee as a chair, and that trustee selects the exam items based on a blueprint as well as how those items have performed on previous exams. So if they're, good items with the desirable percent pass on that item and good discrimination, they also use that information to select items. The test committees review poor performing items, either items that were too easy, they were too difficult, or they did not discriminate well among candidates. And then they see if they can edit them, or sometimes they just delete those from our item bank. They also regularly update our item bank. As you know, there are constant changes in terminology, so they are responsible for being sure that the item bank is up to date with current terminology and concepts. So let's talk a little bit about the actual exam and assessment. So when we talk about taxonomy of questions, it's the level of cognitive skill that's required to answer an item correctly. And so again, there are recall questions, which are in our written sections. And as I said, we're trying to decrease over time the number of questions that are recall, or to make those essentially what's considered walking around knowledge. But more importantly are those questions that are interpretive, where the candidates are asked to solve a problem or consider what the next step is, so that we can really get to judgment and not just memorization of facts. So when we ask our test committees to write items for the exam, we instruct them to ask important or frequently encountered concepts that are medically relevant. The questions need to focus on a single issue, fact, or problem. There should be a single best answer. And again, interpretive and problem-solving items are preferred over simple recall. And we do have criteria, for example, negative stems like no, not, aren't allowed, all of the following except, all of the above, none of the above. Those are not allowed. We use National Board of Medical Examiners standards for our item writing, and actually over the last few years have stopped accepting essentially multiple true-false type questions. Although there are a lot of them in the item bank and they do perform well, we're moving away from things that are essentially multiple true-false questions. So after an exam is administered, we do an item analysis. We look at two very important statistics on each question, and those are the p-value, which is essentially the percent of candidates who got that question correct. So if more than 80% of people got it correct, or less than 25% got it correct, those are probably not good items. They probably don't discriminate particularly well. And so they would be reviewed by the test committees to see if they can edit them to make them easier, more difficult, whatever. And then the other statistic that we look at is called the point by serial, or the discrimination. And this statistical value tells us how well that question discriminated against good performing candidates versus poor performing candidates. So in other words, did good performing candidates do well on that question, and did poor performing candidates do not so well on that question? If so, that's a good question. It discriminates between those who should pass and those who should not pass. So the higher that number is, the better that item discriminates. If an item has a negative point by serial, that means that good candidates are answering that item incorrectly. So we review those, first of all, to see if they're keyed correctly. And then we send them back to the committee to see if, well, maybe it's an ambiguous question, maybe there's more than one correct answer. And those items that perform poorly would be removed from scoring because they do not contribute to the reliability of the exam. We also review exit surveys. So we ask our candidates to fill out an exit survey, and we do take the feedback to continually improve the quality of the exams. And there is a form for commenting on individual items. So, you know, every once in a while, something isn't quite right. So maybe there's the wrong image with a particular question, or someone really thinks that there is no right answer, a number of reasons why we can get comments from candidates. And in our continuing certification exam, diplomates can actually comment on each item. And in the remote exams, you will be able to do that. However, the countdown clock continues, so you wouldn't want to be spending a lot of time commenting on individual items. So whenever we're talking about an assessment, there are three considerations: the validity, the reliability, and the objectivity of the assessment. So content validity means, does the exam test for what it's supposed to test for? So does a dermatopathology exam test dermatopathology and not cytology? So the content should be a representative sample and distribution of the universe of items in a particular field of pathology. The exam blueprints also demonstrate the content and the content validity. There have to be a sufficient number of items for validity of an exam. You can't just give someone 10 items and say, oh, well, we're going to certify you. And we do have sufficient number of items on our exams that are psychometrically sound. The subject matter experts define the content, and they do review the blueprints every year when they meet to be sure that the balance on the blueprints are what they think represent the practice in that particular area. We also do an annual job analysis of our diplomates who have time-limited certificates, and we're always particularly interested in those new in practice pathologists and what they're experiencing in their early years of their career, and we use that to consider content. So, for example, we ask what practice areas are particularly important in your current role, and how was your training? Was it about right? Was it too much, or was it too little? And of course, when it's too little, that's a concern. Reliability is the confidence that we have in our test scores and in our pass-fail decisions. You can think of it as precision. So an individual who passed the exam this week would likely pass next week, next month, next year. So it's the confidence that we have that we're making the correct pass-fail decisions. And then objectivity is reached by having criterion reference testing. Criterion reference testing, which ascertains an individual's ability relative to a criterion standard. So what this means is that it doesn't matter how anybody else does on the exam. You're not graded on a curve. A candidate is assessed against this passing standard, which is set actually in advance of the exam. The way that this standard is developed is we gather subject matter experts, and they review a recent examination, and for every item on that exam, they determine the probability that a marginally competent candidate, someone who should just barely pass the exam, would get that right, or the probability of 100 minimally competent individuals would get that correct. This is called a modified Angoff method, and it's well recognized by psychometricians as a good way to develop a standard for making pass-fail decisions. So again, I talked a little bit about this. So it's just making an assessment, averaging the probabilities across all of the subject matter experts, and then that becomes the standard. And we transcribe that to a scaled score so that passing is 500. And again, if you pass, you don't get your score. If you didn't pass, you do get the scaled score, so you have an idea of how close you were to that passing 500 mark. So again, exams are graded using a criterion standard. All candidates who meet the standard pass. Theoretically, all could pass, all could fail. That's never happened. And the exams are equated for difficulty. So let's say, for example, the spring exam is easier than the fall exam. Spring candidates would have to get more questions correct to meet that criterion standard than the people who took it in the fall. So that, again, that standard of performance stays the same regardless of the level of difficulty of the exam. This shows you what's called a right map, and it shows on the left-hand side, the distribution of candidates. So towards the bottom are the less well-performing candidates, and at the top are the highly performing candidates. And you can see it is pretty much a bell-shaped curve. On the right-hand side on the scale is the difficulty of the exam items. And you can see there are some items down at the bottom that are very, very easy items, where almost everybody got them wrong. Those don't discriminate very well. And those are often items that we've never used on an exam before. We can't field test our items because we just have too few candidates to be able to have non-scored items on the exam. But as I mentioned, we do the item analysis. And if items are too easy, too hard, or they don't discriminate, they are removed from scoring. But what we like to have is item difficulty that is right around the pass point, the cut point, because that's where we're having to make important decisions and discriminating between who should just barely pass and who should just barely fail. We know that people way up at the high end should pass, people way down at the low end should fail, but it's around that pass point that important decisions need to be made. So in summary, our exams are an objective measure of a candidate's ability. There is a criterion standard that is an absolute requirement for passing, regardless of the difficulty of items on the exam. The measurement is independent of the exam taken. So again, an easier exam would require more questions to be answered correctly than a more difficult exam. And this is called exam equating, so that things are always on the same scale and the pass point remains the same regardless of the exam. So once you become certified, just a reminder that the next step is continuing certification. So once you are certified, you are automatically enrolled in our continuing certification program. And you will be joining a cohort of diplomates certified in 2006 and thereafter. So I would say between a third and a half of all practicing pathologists now have time-limited certificates. And you must participate in our continuing certification to maintain your certification. But when we designed our continuing certification program, we recognized that there are a lot of good things that pathologists are doing on a daily basis, and we tried to use those and capture those and give credit for the things that pathologists are already doing that are continually improve their practice. So you need to report to the board every 2 years, and I'll go over the components on the next slide. But every 2 years, you need to report if you have completed a fellowship anytime during that 2-year cycle, or if you're in the physician scientist research pathway, you are not required to report your continuing medical education, and you're also not required to do improvement in medical practice for that 2-year segment in which you were either doing a fellowship or in the research pathway. I'm sorry, I seem to be missing a slide. So I just wanted to briefly go over the components of continuing certification. So the first component is professionalism and professional standing, and this requires that diplomates have a full unrestricted license in the jurisdiction in which they practice and in all jurisdictions where they hold a medical license. The next component is lifelong learning and self-assessment, and that is essentially the continuing medical education. We used to have, or we still in 2020 have a so-called SAMS requirement, which is self-assessment modules, but that's going to go away in 2021. So it's just your continuing medical education, and the requirement there is 70 credits over the 2-year cycle. And your cycle, by the way, it corresponds to the year that you initially got certified. So if you were certified in 2020, an even numbered year, you would need to report to the board by the end of 2022. So if you were certified in an even year, you report in an even year. The third part of continuing certification is assessment of knowledge, judgment, and skills, and I'll talk about that more on the next slide. And then finally, the fourth component is improvement in medical practice. And there are a number of activities that pathologists are routinely involved in that are quality improvement activities. And so we give credit for a number of these. So there's a long checklist of things that will meet that requirement. We ask that diplomates complete at least one improvement in practice activity each year. And they also can design their own quality improvement activities and report those. So there's a form for submitting your own quality improvement projects or your departmental improvement projects. And perhaps the most exciting thing that, oh, there's the slide I was looking for. So these are the parts of continuing certification. And then finally, I want to talk about ABPath CertLink, which will be replacing the once every 10-year exam that was required in the continuing certification program. So beginning in 2021, we will no longer be giving the every 10-year exam, but all diplomates will be participating in CertLink. And what this is instead of a once every 10-year point in time assessment, it's a longitudinal ongoing assessment of medical knowledge. And it's not only assessing your medical knowledge, but it's also formative in that our diplomates are learning while completing this assessment. So the way it is designed currently is our diplomates get a notification at the beginning of each quarter, that's each 3-month period, saying you have 15 new questions to answer. They can log in anytime from anywhere, answer 1 question, 5 questions, however many they want. They have 5 minutes to answer each question. And it is open book, so they can use any resource except another person. Then once they've answered the question, we ask them how confident they were in their answer and how relevant that question is to their practice and how relevant they think it is to the practice of pathology. And then they're given immediate feedback as to whether they got the question right or wrong. They're given a narrative that we call a critique, which explains why the right answer is right and why the wrong answers are wrong. They're given references in case they want to read more about it. They also may receive clones. And clones are presented if someone gets the initial question wrong. They'll get a very similar question in 2 quarters later, or if they answered with very low confidence. And the idea is to reinforce learning and also demonstrate that learning has taken place. And during our pilot, we have excellent data that shows that individuals did retain knowledge after reading the critique and did perform better on the clones than they did on initial questions that they got wrong. And by the way, if they do get the question wrong, after reading the critique, we give them an opportunity to answer it again to reinforce the learning. However, it was their initial answer that is the one that counts. So the diplomates then have a dashboard that shows how they're doing compared to their peers. There's a question history, so they can go back and read the critiques. And also, to make this a relevant assessment, we've identified 31 different practice areas. So diplomates can design their assessment to reflect what they're doing in practice. We do require that 20% of the questions, which is essentially 3 questions every quarter, have to be from your area of primary certification, so AP and or CP. And then if you have one subspecialty, an additional 20% from that subspecialty. If a diplomate has more than one subspecialty, then they're only required to have 10% core questions in the subspecialty. And then the rest of the questions can be elected in increments of 10% from those 31 different practice areas. So, potentially somebody who's doing nothing but blood banking could have 80% of their questions only in blood bank and 20% in their area primary certification, APCP or CP, for example. So this has been extremely well received by our diplomates. And again, we think it's a much better assessment than the binge and purge of a once every 10-year examination. So with that, I hope I've given you some insights into the certification process and what you have to look forward in the future with your interactions with the American Board of Pathology. And I'll be happy to take any questions. Thank you so much for your time.